Hello everyone, and welcome to CK Med. My name is Clark, and I'll be taking you through the first part of our upper limb series today. To first start things off, the way that we're going to be going through this, first is describe the basic anatomy of arterial, venous, lymph, and nerve supply of the upper limbs. And then following that in our second video, we're going to be hitting some of those key points on clinical aspects. As far as basic anatomy, there are some clinical tie-ins, and we'll cover those as we go through this video. But the second one is really where the clinical things come into play. But please don't forget your basic anatomy, because I can ask you a whole bunch of questions, especially on your step one, that involve these certain things. To start things off, we're going to be talking about our subclavian artery. And so off of our heart, which is down here, our heart's down here, we give off this nice arch of aorta. The ascending aorta, the arch of the aorta, and then it goes down to the thoracic descending and the abdominal descending aorta. Off the aorta, and we'll be discovering this in our cardiovascular section specifically, it gives off three main branches. Those three main branches, obviously we do have a connection here that's just a ligament, and that's also very important for connecting the pulmonary artery and the aorta together in neonates or babies in the womb. However, right now, as an adult, this is just a ligament, and this is called your ligamentum arteriosum. But as far as the arch of aorta in a regular adult, without any cardiovascular problems, the arch of the aorta gives off three main branches. Now, being that the heart is on the left side of the body, we're going to need a little extension cord to get to some of our main branches. Now, our main branches are our vertebral arteries, our common carotids, our subclavian arteries, and then some of the little branches that come off of subclavian. But in order to get to that subclavian artery and our carotid arteries, on the right side of the body, we have to have an extension cord, and that extension cord is known as your brachiocephalic. And you can see on the left side, we actually don't have a brachiocephalic. It's simply because your heart's on the left, and so we have to actually reach over to the right side of the body with that extension cord, and that's your brachiocephalic. So only on the right will you see brachiocephalic. And then following that is where kind of our remaining branches come off. So if we were to look on the right side, following the brachiocephalic, just treat this part right here as the same as this part right here of our arch. So we have our right here, our main area of the arch of the aorta is this plus this extension cord, and the left part of the main aorta, and you get off these main branches. And so the first to come off is actually our common carotids. Off of the brachiocephalic is our right, and off of the arch of the aorta itself is our left, is our common carotid. Then following that is our next main artery, which is kind of the last main artery. Again, off the brachiocephalic, after the common carotid on the right, we have our subclavian, which is the right subclavian. And that's this main artery here. Following that on the left, again, second and last main branch is going to be your left subclavian artery. And this is the one that carries on up here. And then following that, on our subclavian artery, we have a bunch of little branches, 4 in particular, that are usually found in all patients, and then a 5th that can be there in some patients. And this is one of our anatomical weird things that sometimes happens in patients. And the way to remember this, as far as your subclavian artery, which is this, again, artery right here, and this main one that comes straight off of the aortic arch on the left, is the mnemonic for this is called vitamin C and D. Now this, again, is that D is the last one we're talking about. That's where it sometimes comes off of this subclavian, but not everybody has this artery. But everybody does have these vitamin C at least. And so those arteries are named specifically with VIT and C. So the first is going to be vertebral artery. And if you go back to our back and spinal nerves, we discussed our cervical vertebrae. And our cervical vertebrae have one defining feature. If you remember and go back to that video, if you watched it, if you haven't, go back and review it because it's going to be on your test. But go back and review that cervical vertebrae. What was the cool thing about the cervical vertebrae or the vertebrae in the neck? They all have that kind of lateral transverse process. And that transverse process actually has a foramen in it, a hole. And so if you drew the vertebral body, and then we came out here, we actually had a vertebral foramen out here. And then we had our spinous process that came out here. And then we had our other foramen over on this side and came like this. And so this is the only found in the cervical region is where we have this hole on the side. And that's actually where our vertebral arteries go and travel through. They go up and go through that circular foramen. Then following that is our eye, which is our internal thoracic artery. This pretty much supplies our intercostals from the top down, as opposed to our lateral thoracic and superior thoracic, which do supply it from the top side and from the side, but those are all more on exterior supply, where internal thoracic is a superior but inside of the thorax blood supply. And then following that, we have our T, which is our thyrocervical trunk, which goes to make sure that you understand what comes and what gets supplied from here. And so if you were to guess what organ gets supplied by the thyrocervical trunk, you'd be incorrect by saying the thyroid gland. And so this thyrocervical trunk gives off your inferior thyroid artery. And this is an important kind of concept when we go to discuss endocrine as far as anatomy goes, or head and neck anatomy. When we get there in your neuro section in term 2, we'll be discussing our blood supply to our thyroid gland. And it also supplies things of the neck and gives off aberrant arteries such as your transverse cervical comes off of your thyrocervical trunk, and your transverse cervical goes, and we'll be discussing this in a few minutes, for your scapular anastomosis. So just keep in mind that this is the trunk that's very important. That'll come up in a further slide. And then lastly, after our T is our C, and that's our costocervical. Pretty much this just gives blood supply to the musculature of the neck, and it's not that important of an artery, but that is the C and the last branch. And then our last, only in some patients, aberrant artery, this D, is actually dorsoscapular. And this does play a part in your scapular anastomosis, but again, not everybody has this. Only a few, like a small percentage of the population, maybe 20 or 30% of the population, have this artery, dorsoscapular, and it helps out with our scapular anastomosis. And you might be asking, what on earth is this scapular anastomosis? Well, we'll be discussing that shortly. Following this, following the subclavian artery, which is right up here, if I were to draw it, subclavian was here. Once the subclavian passes under the first rib, meaning it's going out towards the arm, it goes under the first rib, which comes off of your T1 vertebrae. Then this becomes a new artery name. This is kind of the dividing point. Once it's here, it's subclavian. And after, it's called your axillary artery. And this axillary artery is very important clinically because it has lots of a cool anatomy that we can actually test you on. And so this really, really sucks. Everybody hates this axillary artery. They're like, oh my gosh, there's so many branches and I'm forgetting them all. I wish I had a really cool or really funny story that I could practice 3 or 4 times. I'd get really good at it, and then I'd have this thing memorized like bam, and I could tell someone this full story all the way through. I'd have all the branches memorized. I could draw it up on a board. I can make really fun jokes as I'm going throughout this. I would be really good at telling this story, and I'd never forget my axillary artery. Well, let me tell you that story. So the way that you remember the axillary artery is first you have to set up your dividing points. Your axillary artery is set up into 1, 2, and 3 sections. So section 1 here, section 2 here, and section 3. And this artery is divided into these 3 sections based on, again, another anatomical structure. We described subclavian turning into axillary because of the first rib. Well, we also have this artery, which is our pectoralis minor. Our pectoralis minor is a very small muscle that's found that overlies this section 2, and that is our dividing feature. If it's more proximal to our pectoralis minor, it's section 1. If it's under our pectoralis minor, it's section 2. And if it's distal or beyond our pectoralis minor, it's section 3. And the best part is, once you have these all sectioned and you understand what is dividing the sections, then you can go with the story. And let me tell you this wonderful story. Once upon a time, there was this small town, and this small town was known for this phrase: 60s teens love sex and pot. Now, this might not be the town you want to hang out in, or maybe it is the town you want to hang out in, but 60s, teens, love, sex, and pot is a way to remember all the branches of your axillary artery, which you can see all these little small ones. They're not all labeled here, but they are labeled with our associated letters found in this picture here. So we have our heart, it's going out to our arm. Our axillary, or our shoulder artery, is the one that we're describing, and we're trying to understand what are all the branches. And so if you can remember, section 1 has 1 branch, section 2 has 2 branches, and section 3 has 3 branches. So 1, 2 has 2, and 3 has 1, 2, 3 branches. And so just keep in mind, as you're watching this slide, as I'm going over this story with you, please keep in mind and look at your shoulder. Just imagine this artery found right here, and you have your pec minor overlying this, going up over to your shoulder, and you have this artery running right through here. And now associate it according to a giant box. And this box is going to be your thorax. Thorax is the box right here, okay? This is the main thing. Everything that kind of underlies, if I were to draw a box thorax, you can see that if you're looking at your shoulder, you see the box. If you just make your thorax into a box instead of the actual kind of strange shape, bullet shape, I guess the thorax is described. I don't know how to describe that, but box is your thorax, okay? So in the first area here, you could see that this artery likes to come down and supply the top of the box. And so you would say, what would be the name of an artery that comes down right here to the top of a box, and that box is called thorax? Well, that means it's the superior part of the thorax, and so guess what we call this artery? It's called superior thoracic. Great, done, the end, nice. That is section 1. That's all you need to remember this. And so that is 60s. 60s is superior thoracic. It is the first artery. It's also on the highest point of your axillary artery. It's on top of the thorax, so it supplies the superior aspect. That's why we call it superior thoracic. Now we have our mnemonic. So these 60s teens, now we're in our second sections, these 60s teens are going to be our next branch. And this is called your thoracoacromial. Now, this might take you a few times to actually write down, but it actually is at your thorax and your acromion. You've now come down to your acromial process. If you don't know what that is, please review the different pieces of your scapula, and I will put this out later as well. But your scapula has a little process that kind of extends out, and that's called your acromial process. You can actually poke it on your shoulder unless you're very muscular. So thoracoacromial is something that gives off a blood supply to 4 different branches. So let's describe this. We have 60s in the first, 60s teens, and when they're growing up, meaning that's the direction that this artery goes off, is actually upward. It goes up. So 60s teens, when those teens grow up, well, eventually they get old, and they get so old that they die. And you know, cadavers are dead people. Cadavers are dead people, CADP. So that is your clavicular. So you might ask yourself, where does that go? Well, it supplies your clavicle. Again, all in this area. It goes to your acromion. So acromial process is where this artery goes to. It goes to your deltoid. So you might ask yourself, where is this going to? That's your deltoid muscle. And then lastly, pectoral artery. And so again, 60s, superior thoracic. Teens, when they grow up, they go upwards. Eventually they get old and die, and you know, cadavers are dead people. Clavicular, acromial, deltoid, and pectoral. And then these 60s teens love, well, now that we've come a little bit down onto the side of your thorax, we now have this artery that comes to the side of it. And you might think, I wonder what I would call that artery on the side of the thorax. Well, side is also another word for something that starts with an L, and that is lateral. And since we're on the thorax, thoracic. So your L of love is your lateral thoracic. So 60s teens, as they grow up, cadavers are dead people. Love for lateral thoracic, that has now accomplished the first and the second section of your axillary artery. Now, the last section, and this one is the most enjoyable for lots of people. Maybe not for me, but some people do, obviously. But this next section, 60s teens love sex and pot, these last 3 arteries. Again, third section has 3 parts. So SAP, and we're going to describe those. So 60s teens love sex. And well, when they're having sex, they're going down on each other. As you can see by this branch actually going downward. So this is actually your subscapular artery. So your subscapular artery, as the S of sex, as they're going down on each other. Well, when they're going down on each other, eventually they get STDs. And so these are the branches that come off of your subscapular artery. And I know this seems like a little weird. Why is this an S? This is your scapular circumflex. And this is a very important artery we'll be coming back to when we do our anastomosis on the next slide, actually. So our subscapular gives off our scapular circumflex, meaning it's going around the backside of our back to our scapula, our shoulder blade. And then our thoracodorsal. Dorsal. And our thoracodorsal goes to our latissimus dorsi muscle. And that's a very important artery for our lat pull downs, if you ever do those at the gym. So 60s teens love sex. As they go down in each other, eventually they get STDs. That's our scapular circumflex, thoracodorsal coming off of our subscapular artery. And then lastly, we've now come all the way down our axillary artery, all the way through the first section, all the way through the second section. We've now come to the last part of our third section, and we are at the point where we're pretty much at the top of the arm. Now that we're top of the arm, you describe, well, I have an A, and I have a P, and both of these arteries circle around something. And you might ask, what is that thing? Well, if I were to just draw a bone that kind of goes right through here, that goes to our arm, you might laugh because it's quite humorous. Okay, so the humerus bone actually runs right through here. So if I have an A and a P artery that circle around the humerus, you can imagine what A and P of and pot would actually be describing. And so this is your anterior and posterior humeral, because we're dealing with the humerus, circumflex arteries. And you have now accomplished section 1, section 2, and section 3 of your axillary arteries. 60s teens love sex and pot. Please practice this a few times and teach it to your closest friends, or your girlfriend or boyfriend if you have it. Maybe don't be doing all of these things. You should be focused on your studying. But again, this is a great way of remembering this. If you draw it out a few times, and if you draw it and tell the whole story as you're drawing it, you're going to be solid on your axillary artery. And then you might ask, Clark, are they really going to sit down and ask me the branches? Well, on your clinical lab anatomy exam, where you have to go into the lab and identify specimens, all of these branches are high yield to point out. So keep in mind, be able to practice and point out all these arteries when they're tagged for your lab exam. Also, these can be tested because of this. Our axillary anastomosis, our scapular anastomosis is pretty much what we're going to be talking about here. So our first section, remember that was our superior thoracic, came down to the top of the box. Our second gave off our thoracoacromial, which is a branch that gave off all the cadavers or dead people. And then our lateral thoracic gave off on the lateral side. And then our third section gave off our subscapular and our humeral circumflexes, A and P. Well, that subscapular is a very important artery because it circles around to the back and comes up right here. So here's our axillary artery right here. And you see that it gives off our subscapular right here, this branch right here. And then off of our our subscapular artery, we give off this circumflex scapular, and this comes back to anastomose and meet an artery branch that comes from higher. And now, if you can ask yourself, I have my thyrocervical trunk right here, which we discussed earlier, giving blood supply to the thyroid, and also giving supply for our different branches, such as our suprascapular artery and our transverse cervical. All these guys come down eventually to anastomose with our circumflex scapular. So they all kind of circle around, they come up and hook up to this subscapular / circumflex scapular artery and anastomose. And you might be asking, why is this important? Well, let's describe a clinical vignette. I have a 55-year-old female who is taking oral contraceptive pills, not for contraceptive, however, for oral estrogen and progesterone replacement therapy. She's postmenopausal. And these drugs increase clots. And that can be arterial and it could be venous, mainly venous, but it can be arterial as well. And for some reason, she gets an arterial clot, and a whole bunch of them all over the place, and one actually occludes the second part of our axillary artery, right here. And so when this gets occluded, how will we get blood supply to the arm? And you might go, well, since we're on the axillary anastomosis point, we might actually have blood that comes from the heart, comes up, goes through a thyrocervical trunk, goes on the backside to come down over here, anastomosis, and then hook into the third part. Remember, our second part's occluded. It hooks into the third part and then continue down to the arm. Now that is a free point on your test if you can remember all the parts of that anastomosis. So again, this is pointing out the important parts here, but as far as our scapular anastomosis, please remember this box right here. This is going to save your life to make sure you pick at least one of these correct arteries here. So if I have an occlusion of my second part of my axillary artery, how does the arm get blood? Well, be looking for our subclavian, or a branch off the subclavian known as our thyrocervical trunk, which gives off our suprascapular artery or our transverse cervical artery, which then hooks up to our circumflex scapular, which goes to our subclavian and enters in, or our subscapular, sorry, and then hooks up into our third part of our axillary artery and continues down to the arm. They will not give you multiple of these on here, okay? You just have to identify all of them. So when that one of these is an answer choice, bam, you click it, you move on to the next question, you just got a free point, okay? Please remember this. This is where a question comes off for axillary anastomoses. Okay, now that we've covered arterial supply of our upper limb, as far as like the big things, we'll come back to our lower forearms and stuff. But as far as our shoulder goes, what else is in the shoulder? So we have things in our shoulder in the nervous realm as well. And this is actually a super important thing that comes up not only on your exam now, on your 5th term exams, your BSE 1, BSE 2, your CBSE at the end of term 5, and your step 1. So please remember your brachial plexus. Now, you might ask me, hey Clark, do I actually need to know every single tiny little branch that comes off of here? The answer is no. You do not. I can actually cross off a couple on this picture here. You don't even need to know. However, we're going to kind of cover the brachial plexus as a whole and describe what's going on, because everyone gets confused when we're talking about our dermatomes in regards to our like our cervical spine and our spinal nerves versus our dermatomes for our specific nerves like musculocutaneous, axillary, median, radial, and ulnar. Everyone gets kind of confused what's happening. So I wanted to throw in this picture. It's a fantastic picture describing and showing you the fibers of each of these. So the brachial plexus is made of C5 to T1, as you can see down here, all the way down here. And these are the main branches that make up the brachial plexus. Now, it would be great if our musculocutaneous was just C5, and our axillary nerve was just C6, and our median nerve was just C7, and our radial was 8, and ulnar was T1. That would be fantastic. You'd be done. You can move on. However, of course, with our wonderful, fantastic anatomy, there's actually really cool, that's sort of a safety mechanism, allow you to not lose an entire section of your arm just by hurting one entire nerve. If you hurt some of these little fibers, you're going to lose a small section that's going on, but not entirely destroy the entire use of our C5 dorsal root right there, or ventral root, sorry, motor. So if we're describing how our brachial plexus is split up, these are our main arteries, or our nerves that come off of here. These are the 5. And there's a way to remember this. If you hold out your hand, it's our C5 is made out of three roots, C5, 6, and 7. And so you can see this red, blue, and green. And so that's our 3 musketeers. So musculocutaneous is the 3 musketeers. And 3 musketeers assassinate. So if you do a gun sign with one finger, your index finger as the barrel and your thumb as the hammer of the gun, then you have assassinate. So 3 musketeers assassinate. So that's going to be first 2 roots. So actually, if I drew a hand for you, so here's my thumb, my thumb is my C5. And then I have my other fingers here. Oh my gosh, these are really fat fingers. Sorry about this. And they get bigger and bigger. Okay, wonderful hand here. So a C5, C6, C7, C8, T1. Okay, so if you use these first 3 fingers, it's 3 musketeers. And then you use the first 2 for your assassinate. That's the gun symbol. And so that C5 and C6 make up our axillary. You can see the color fibers here, which makes it really nice. And then what do they assassinate? They assassinate 5 mice and 5 rats. And so all 5 of the roots make up our median. All 5 of the roots make up our radial nerve. And then lastly, a unicorn. And you might look at this and go, what the heck is this? Well, if you took your last 2 fingers, closed up the fist on your thumb, your index finger and your middle finger, and then you stuck this like a big A-OK with 2 fingers instead of just 1 on your forehead and stuck up these 2 fingers on your head, then you have a unicorn, which is the unicorn horn. So if I'm going to draw a little guy's face here for you so you can picture what the heck I'm even talking about. So he has his A-OK sign of his index and his ring finger, and then he's got his 2 remaining fingers up here sticking out, and his thumb's kind of wrapped in here, and he's got a unicorn, and he goes, nay. Okay, so that's your unicorn. The last 2 fingers are C8 and T1. Okay, sorry, it's a little obnoxious, but you can also see it as far as the colors in each of these fibers that this makes up from the main branches as far as where they come from. And so it's nice to actually see this picture that our C5 root splits off and goes to a whole bunch of nerve, kind of supplying little fibers within it. Remember, this is a whole bunch of nerves. It's not just one. It's like a whole bunch of nerve fibers or individual cells that are flowing through here. So part of it goes up here, part of it goes up here, part of it goes here, and here, and here, and here. It kind of shares and spreads out its wings there. And so that's kind of an important part of how these nerves are made up. So if I were to look just at C5 dermatome, it would be quite a big dermatome that would go all over to wherever these nerves have sensory. Where if I just were to look at musculocutaneous, it would only have these certain small fibers where that sensory is going. And we'll be describing each of these as we go. So here's kind of a basic simplified, so you don't have to look at all these different colors here. But this is the basic simplified of our brachial plexus. We start from our C5 down to T1 here, and then we have from there, it kind of fuses together to make our trunks. And then following from that, we kind of divide our trunks into multiple different places, and that's our divisions. And that's where some of the fibers kind of go from different places all over the place to kind of share and go even down to radial and median nerve down here. And then we have our cord, which is our lateral, our posterior, and our medial. And then our branches, which are pretty much the 5 main nerves that we're going to be talking about of our brachial plexus. There is a great, wonderful YouTube video if you need help practicing drawing this. I think it's called like the brachial plexus made ridiculously simple. This guy goes through this cool way of drawing 3 Ys. So you just do the big Ys like this, and then you have another Y like this. Actually, sorry, you have three Ys on their sides like this. I'm going from C5, 6, 7, 8, and T1 from this way. I'm going from this way, kind of mirroring this picture. So 3 Ys, and then you make like 2 Es, which kind of are like the epsilon Es, like this. That's a big E there. And then we have another one that kind of comes in down here in the middle, like this. And so this is our median nerve here. This is our musculocutaneous. This is our radial. This is our axillary, our radial, and then our ulnar nerve down here. So that's kind of the way that he does this little drawing, and then there's like 1X that you can go through here. But just follow along that video if you get confused from whatever I was just describing. But just make sure you get your main roots, your trunks, divisions, and cords are cords and branches, and kind of know where they're going and what's their function. There are a few other small nerves that kind of come with this. I'm going to come back to this picture actually here. Some of them, like your long thoracic, we discussed in our back and spinal nerves. That is something that's important for wing scapula, and that supplies the muscle called your, does anyone remember? That's right, serratus anterior. Serratus anterior is that muscle there. Obviously subclavian, that goes to like different muscles around your shoulder area. You have your suprascapular that supplies your supraspinatus muscle and stuff like that, and our infraspinatus as well. And then a couple other ones that do come off of here, but there's really not that many. Long thoracic's the one that they usually ask. Okay, so as far as once we describe those main nerves of the brachial plexus, where do they go? What do they do? Well, we're going to be discussing some of our sensory dermatomes here before we discuss some of the motor things that come along with this. So sensory dermatomes, you have to associate first a nice layered pattern for our basic dermatomes of our roots. So C3 and 4 up on the shoulder, 5 on the lateral, 6 kind of on the lateral forearm and thumb. And then we also have our middle index of 7, our medial, which is our pinky and hypothenar, is C8, and then our medial arm, forearm, is going to be T1 and T2. And this T1 and T2 is very important for referred pain because our cardiopulmonary pulm nerves, when someone has a heart attack, they have referred pain to our T1 to T4 area, which is our chest, as well as our arm. And that's actually where this dermatome comes into play. So that's kind of the basics. You can just kind of walk through this map really easily. And that's not that bad. What everyone gets really confused is when we're talking about all of our upper nerves, as far as sensory in the arm, that are our main ones, like radial and musculocutaneous and median and ulnar. Everyone hates these ones. But I want to apply this basic concept to you. That when you come off your brachial plexus, you have both motor and you have sensory nerves coming with it. And if you can remember this, okay, so I have my spinal cord, and I'm going to draw my spinal cord here. This is my spinal cord and our spinal cord here, okay? And if you can imagine these as little guys with their little arms and the nerves. And so if I were to zoom in on this spinal cord here, we have our little central canal, and we have this kind of ventral horn right here, and our dorsal horn. This is going to be sensory, and our ventral is going to be motor. And from our motor, we have little guys in here. And I'm going to draw these little guys, and they're all smiling like this, and they have crazy hair because they have all these dendrites. These are our motor fibers. Our motor fibers are only unipolar. And what that means is they have one cell body, and then they send out their arms to reach into the arm. And this is where they synapse and contract a muscle out here in the arm. So they can only reach certain far, almost pretty much one arm's length. One arm's length, because they have their head up here and they just reach out with one of their arms. Just imagine these little guys. However, in the sensory, on the other hand, their head is actually out here. So here's the little sensory guy, and he's got his little dendrites out here. But he uses his left hand to grab onto over here, and he uses his right hand to grab on over here. And so you can see that we have one arm length, so this is 2 arms length. So you can see that motor can only reach a certain distance, but as far as our sensory, they can reach 2 distance. And if you actually look at the nerves themselves, if you go up and look at motor neurons, like an actual picture of a motor neuron, it looks just like this. Cell body, dendrites that come off, and then it just goes out here, and then we have the little terminal of the axon that comes out here. This is a motor neuron. See, there he is, smiling. So he only has 1 arm length. But if you look at our sensory nerves, these are actually what is known, not bipolar, but are pseudo-unipolar. And what that means is they have our little terminals out here, and they come back, and they have their head like this. Here's their head, and then they have continuing of this process, and they synapse up here. This is actually what these guys look like. So these are sensory, and these are motor. And this is actually why I kind of put this in there. And it's actually a really great way of remembering that first comes motor, then second comes sensory. And so if the nerves are coming and reaching out, the motors can only reach a certain distance. So let's take our musculocutaneous nerve. Okay, our musculocutaneous nerve descends into the arm and it gives off its motor first. Remember, motor can only reach a certain distance, so it reaches first. And that is going to be our anterior flexor compartment of our arm. So what this does is it flexes our forearm. This is biceps, pretty much. It goes to our biceps compartment. And what this muscle does is it cracks through a muscle. There's one muscle here that it cracks through. It breaks through this muscle. And the way I remember this is your coracobrachialis. So the musculocutaneous coracos through the coracobrachialis, is that muscle. So if you ever get that question, like I look in the flexor compartment of the arm, I separate and pull back our biceps muscles, and then I see a muscle where a nerve penetrates it or coracos through. What is this muscle? That is your coracobrachialis. And so the motor ends. So if you can just remember this concept, the motor ends, but then sensory continues. Sensory continues this way. And so sensory is going to reach all the way down out over here, and that's why we have the lateral forearm as our musculocutaneous. So the concept here is this. If I'm coming from a medial side, so here's the arm, I'm medial to the arm, I come down, I give off motor, and then I continue coming from medial to lateral in this direction. This is where my vector is going. I'm going from medial to lateral across the arm, like this way, right? This will come down to the lateral forearm, and that's where our musculocutaneous gives off its lateral cutaneous nerve of the forearm. So that's a way to kind of remember this. Whatever direction physics drives this nerve, it's going to give off motor, and then it will continue as the sensory coming out at the end there. And so this concept actually can directly apply to a lot of our other nerves as well. So we have another nerve on the back side of the arm. So on the back side, what I'm going to do, I'm going to erase all the text from here. And so you can actually see this, but erase all ink on slide. So next we're going to look at the back side of the arm. So if we look at the back side, we have a nerve that runs down here, and it comes from our medial aspect again. What is it going to do? It's going to supply first our motor. And this stops right here in synapses. And guess what this is? Triceps muscle. So this is your extensor compartment. Once it gives off the motor, it continues from medial to lateral to this guy. So posterior cutaneous of the arm is going to be your radial sensory. So radial nerve gives off motor to your triceps motor first, and then it continues as your sensory to the back side of the arm. So this is the general direction that the radial nerve is going, but on the back side of the arm. And that's great, now that we've covered this nerve. Next is going to be our ones more involved in our forearm muscles. And so the way you describe it, so this, again, look at the anterior side here. Next is going to be our median nerve. So the median nerve comes down and it goes right over the middle of your antecubital fossa. So if you get stabbed in this area and a nerve is injured, guess what nerve you're talking about? Your median nerve. Because it's actually medianly. It's literally right in the median of the arm. It will continue into the forearm in the midline. And guess what? This is the end of our hand of our motor nerve. So its synapse is here in our anterior compartment. So it's going to do all our flexors of our wrist. So if you look at your wrist and you flex your wrist as if you had your hand in front of your face and you were to flex and smack yourself in the face, that's what this guy is doing. This is our median nerve. And our median nerve gives off motor first, and then we'll continue into the hand as our sensory. And that's going to be our median nerve sensory of the hand. This does our thumb, and our first, our second, third, and fourth, or half of our fourth digit, shares it with ulnar nerve. And then, which is great. So everything's kind of right in the middle here of the arm. We do motor in this area in the forearm, flexors, and then we do our sensory here. And then we have our ulnar nerve. Now, our ulnar nerve has one special thing. I'll be teaching that as far as its motor. But ulnar nerve has an extra long motor nerve. Because it's at the bottom, it has an extra reach. So this moves medially. So if you fracture your humerus at the medial epicondyle, you're going to hit the ulnar nerve. And your ulnar nerve, again, reaches down and ends up innervating motor-wise First, one muscle, which is important for flexing of your wrist towards medially, and that's called your flexor carpi ulnaris. That's one muscle it does in the forearm. But then its main function has a little extra reach to do all the muscles of the hand, or most of the muscles of the hand, intrinsic muscles. So, you know, doing scissors with your fingers and stuff like that, that's where our ulnar nerve does its motor. And then guess what? As it finishes its motor, it continues as our sensory and will do all the medial aspect of your hand and sensory. So this concept of coming down, giving off your motor, and then continuing down with your sensory in that area is kind of a nice broad concept that you can apply here. Now, as far as the basic sensory, we're going to be describing some of the pathologies of our hands and our upper limbs in the second video. So, you know, definitely watch out for that video, because we'll be describing our ulnar nerve, our median nerve, and all those different nerves as far as deficits in further detail. But lastly, I kind of wanted to describe what are the other arteries of our upper limb. We already talked about our subclavian, which is in the top of our thorax. We talked about our axillary artery, which also is the top and the side of our thorax. And that then leads to, once we get out of the axilla, we then become our brachial artery. And this is this. So once I do my little circumflexes around anterior and posterior, A and P here, we now become our brachial artery. And our brachial gives off one deep branch. This kind of just ends in around the humerus, supplying like the posterior part. This is important for the posterior part of the arm, posterior arm, and as well as the bone, the humerus itself. So if you have a fracture right across the bone here, you can damage your deep brachial artery because it's deep. That's what that's called that for. Our brachial artery then crosses over this antecubital fossa. So if you have someone like a phlebotomist that decides to take blood, wink, wink, wink. This was on a step exam at some point in time of a very nice guy that makes YouTube videos for students. A phlebotomist decides to draw blood from our antecubital fossa, which is this guy right here. And instead of piercing a vein, they stick it in, and he sees pulsating blood into the little blood drawer thing, the little phlebotomy thing. What is the artery that's likely pierced? Well, at the antecubital fossa, this is your brachial artery. Right in the midline. If you push really hard, you might be able to feel it in there. And that's your brachial artery. Once it passes the antecubital fossa, it becomes some of your common interosseous muscles. It becomes your ulnar and your radial arteries. Your common interosseous is actually one of the next ones to branch off, but keep in mind that is not in the antecubital fossa, neither is the radial or ulnar. And the interosseous muscles pretty much the common one becomes an anterior and a posterior interosseous. The anterior one supplies the deep muscles of the forearm. So you might be asking, what are those? Well, those go with all your median and ulnar nerves that supply the forearm muscles here. What's the artery that goes with it? Anterior interosseous. The posterior one pierces this membrane. There's actually a membrane between the bones. It pierces through to the backside and supplies all your extensor compartment. And this is your posterior interosseous. Posterior interosseous gives the extensor muscles some of that blood supply there. And that's actually supplied motorily by your radial nerve. And then we also have our ulnar and our radial arteries. You can feel those in your forearm. You can test them with a fantastic test, which is really actually fun to do if you're ever bored and you're sitting there and you're squeezing your arm. This is something you can do. It's known as your Allen's test. You pretty much what you do is you tell the person to squeeze and make a fist to get all the blood out of their arms. Then you push down on their ulnar and you push down on their radial and tell them to open their hand, and their hand's going to be really pale. And then you unocclude one of the arteries, your radial artery, and the hand will turn red and be filled in if their artery is working. You do the same thing, squeeze again, squeeze both arteries, and this time when they open their hand, you let go of their ulnar artery, and if that fills in, then their ulnar artery is totally fine as well. If one of those is occluded, they can have cardiac bypass using any of those arteries. So that's actually why we do that test, and you'll learn that in your lab class. And then these radial and ulnar come and circle around and make a deep palmar arch. And the arch gives off all these little things that you don't need to know. Okay, these are not important. It's pretty much metacarpal arteries and digital arteries. That's what comes off of there. That's not super important. Just knowing that the ulnar artery and the radial artery do an anastomosis at this point. So if I have an occlusion of one of the arteries, it still can supply all of the hand through this anastomosis arch. That's kind of the clinical aspect of that. And when you get to ortho on your clerkships, then you're going to get to do some hand surgeries most likely, and you'll be able to be tested from the surgeon a little bit about some of those arteries in this area. Okay, now that we've covered the arteries, let's look at some of the veins of the area. Now the important ones are pretty much defined on where they're draining, and that's kind of what I want to get at. I want to describe our lymph drainage after this, but the veins are actually really nicely oriented. So I'm going to do a nice circle of the arm. If I have the lateral arm, meaning a lateral part of the arm here, this is all going to drain into an artery known as your cephalic vein. So lateral of your arm, it goes into your cephalic. Everything medial, so like all the fingers here, medial forearm, medial arm, all these guys drain into basalic. So medial, these go to basilic veins. Okay, and that's pretty much all we need to know. So if I have some sort of infection, it's going to spread by the venous thing, separated by medial or lateral. Medial goes to basilic, and lateral goes to cephalic. That's pretty much all you need to know is the main veins that drain here. And where do they end up going in? Well, your cephalic skips up actually up to your axillary artery or vein, and then your basilic has a whole bunch of little pieces and branches and stuff like this, but this actually ends up continuing and actually making up our axillary here. And so this is, they both drain into axillary vein, which then goes into subclavian vein. And remember, on the right side, it goes into brachial cephalic. We need that extension cord. If it's on the left side, there's no brachial cephalic. It just goes straight into your superior vena cava is where that comes from. Okay, now one of the last things I want to kind of discuss with you is the lymph node drainage. So again, associated with where the area is being drainage. So this kind of hooks in a little bit. The axillary lymph nodes are not only for upper limb, but also for your thorax. This is a very important thing to know. And so your thorax actually gets drained pretty much if you divide the nipple in half. Our lateral chest is going to be going into our pectoral nodes. Pectoral nodes. The way they also describe these are anterior nodes. Okay, and that's why I have them right here. As far as our medial side of our chest, they will go to our parasternal nodes, and that's going to drain all this area here. And when our parasternal nodes drain, it actually can cross over into here. So you can see these kind of lymph drainages here can connect. So if you have cancer in one side of the chest, why does it get over to the other? Well, not only are each sides actually predisposed to being increased risk of cancer, but it can actually travel lymph from one side to the other via our parasternal nodes. Please remember that. But as far as our lateral part of our chest, that's going to go to our pectoral nodes. And then from our pectoral nodes, that's going to go to our central nodes. Our central nodes here. And then it eventually makes its way up to apical. And then it will go back into thoracic duct. Okay, so this is the chain of command. Thoracic duct at the top, then apical nodes, then central lymph nodes, and then central lymph nodes has all the branches. Our pectoral, it has our lateral, also known as our humeral lymph nodes here. And then it also has, from the backside, posterior nodes, also known scapular, because the scapula is in the back. So that's obviously why it's posterior. But remember that there is one aberrant branch. The lateral is the one that comes off humeral, but we also have a second part of the humerus. So this is where, again, we're looking at the arm. This is our arm. We have our thumb and our wonderful fingers here. Okay, this is, I don't know, that looks like a tree trunk. But this is arm. This is a thumb right here. I'm going to label this so you know, okay? So remember, our lateral arm went up with our cephalic vein, as we were describing. Well, just imagine the lymph is going to do the same thing. If you have a thumb infection or a lateral forearm infection, the lymph drainage is going to kind of skip up above. And remember, our cephalic vein with the C is going to be here, is going to skip over our central nodes and actually go straight to apical. So this is one actually weird aberrant thing, is I have my central nodes here, and this is going to get for my lateral nodes here. And the lateral nodes actually just mean arm or lateral to the body, but it's actually draining our medial side of our arm. Goes to lateral nodes, go to central, then go to apical. But if it's a lateral arm, lateral thumb kind of thing, it's going to drain actually all the way up to apical and skip our central nodes. So this is like one weird thing that happens with the axillary lymph nodes, is that we can actually skip and do this. If you have obstruction of our pectoral nodes on the anterior part, you're going to get Pudae orange. So that's a blockage of lymphatic drainage. That's something you can see with breast cancers that obstruct that. If you have obstruction of your lateral nodes, or like the drainage into your lateral nodes from your arm, you're going to have lymphedema of the upper limb. Now this occurs when we actually cut out those things during radical mastectomies and lymph removal during breast cancer treatment. So those things can occur as well, but this is just something that comes along with more clinical aspects of that.
MedSchoolTutors!
You're at SGU and you're thinking about Step 1. There are so many resources and so many opinions. How do you know which path to take? You've worked so hard and you deserve to match into the specialty of your dreams. MedSchoolTutors has helped nearly 1,000 SGU students get their best scores on their CBSE and USMLEs through highly personalized one-on-one tutoring and individualized advice. Our SGU students see average Step 1 score increases of over 30 points when working with us, scores that are their tickets to competitive residency spots around the country. Schedule your free phone consult today to be matched with your tutor. MedSchoolTutors. Get where you want to go.